Good morning, good afternoon, good evening, depending on where you are right now. But surely I am delighted to be with all of you here online. So what I will be sharing with you today is an overview of bone marrow transplant treatment. Where are we now and the interesting development in the field of gene therapy. It is actually a very big task as the audience today range from our beloved patients and their families to doctors and nurses and other healthcare professionals. So I hope that this sharing session today will be educative to the patients as well as informative to the other healthcare professionals. So let us start with a simple and most important question. What is bone marrow transplant? So bone marrow transplant is a procedure to infuse healthy blood forming cell, also known as the hematopoietic stem cell or HSC. Thus, it is now preferably known as hematopoietic stem cell transplantation or HSCT. So I will be using this term BMT and HSCT interchangeably during this presentation. But HSC is a pluripotent cell. What it meant, it has a potential to regenerate and become many other type of blood and immune cells as shown here in this figure. So this HSC can be isolated from the bone marrow, peripheral blood, and also from the cord blood. And until the early 1990s, the bone marrow represented the only source of stem cell. However, this practice had been replaced by peripheral blood cells, and more recently, cord blood had been shown to be a good alternative source for HSC cells. So once we already harvested the HSC cells, upon infusion into the patients, this HSC will travel to the bone marrow and subsequently generate new healthy marrow. And if this is successful, we hope that it hopefully leads to a production of a new and a healthy blood and immune cells. So in PID diseases, where the cause is dysfunction of the HSC to generate a healthy blood and immune cells, this BMT procedure replaces the inefficient patient immune system with the donor one, the healthy one. And this is currently the curative treatment for many PID diseases, mainly in the case of severe combined immunodeficiency, or SCID, with called Adli syndrome, WAS, chronic granulomatous disease, CGD, and HLH. So, so how is HSCT or bone marrow transplant is performed? So HSCT involves the use of these hematopoietic stem cells harvested from the donor, where the donor can come from a related family member or an unrelated matched donor. So the collected and processed HSC are then infused into the patients. But before the infusion, the patient usually will be treated with conditioning regimen involving the use of different type and dosages of chemo and or radiotherapy treatment. So as we can see in this slide, PID field definitely is the main contributor to the development of BMT or HSCT treatment in the field of medicine. As you can see in these landmark events, the first bone marrow transplant was performed back in 1968 in patients with SCID, and subsequently again in the field of PID leads the way in the development of bone marrow transplant, as the first unrelated donor marrow transplant was performed in 1973, again in the patient with SCID. And as you can see here subsequently, PID also leads the way being the first to perform a haploidentical marrow transplant in a patient with SCID back in 1980. So we can safely say PID, primary immunodeficiency, had more than half a century of experience and wisdom in the field of bone marrow transplant or hematopoietic stem cell transplantation. So as you can see now, HSCT or bone marrow therapy is already expanded its role in the field of PID, being a treatment for many other diseases as listed here, not just SCID or CGD or Adli syndrome, and HCT now includes treatment for other PID diseases such as DOP8 deficiency and congenital neutropenia syndrome. So with more than 50 years of experience leading the way in bone marrow treatment or HSCT treatment in PID diseases, especially in SCID, the PID community now definitely have more wisdom and experience that contribute to our knowledge of this treatment in the field of medicine. And among the things that we know now with more than 50 years of experience include several important points. I think the first one is the younger the patient at the age of transplant, the better the outcome of this treatment. In fact, with our experience in the field of severe combined immunodeficiency, patients who are transplanted before the age of 3 months have a better outcome compared to those transplanted at later age. More importantly, what we also know, then other than the younger the age at the time of transplant, making sure that the patient is infection-free at the time of transplant is an important indicator for a successful outcome in bone marrow transplant, as we can see here in the graph shown at the side. So additionally, with our experience, we have shown that patients with successful myeloid engraftment have an earlier and better immune outcome. So thus this leads to the current trend to include pre-transplant myeloablative conditioning as part of HSCT treatment in PID diseases, as the outcome is more favorable. And additionally, last but definitely not least, we have a very good data and experience to show that the outcome in match-related donor transplant perform better than patients who underwent match-related donor bone marrow transplant. So as shown in this data collected among patients underwent HSCT in patients with Wiskott artery syndrome. Here. So thus this will bring us to the challenges in performing this bone marrow transplant or HSCT in patients with PID. So the main thing is to make sure an optimal time of transplant, not just diagnosing them early, but to make sure that they are infection-free and well at the time of transplant. So this will include for a prompt treatment to any kind of infection, resolve any sign of autoimmunity, and enhance nutrition prior to transplantation. More importantly, it's about getting the suitable hematopoietic stem cell donor. Having a match related for patients with genetic disease such as PID, the chances to have histocompatible sibling who is healthy is usually less than 25%. So even the match unrelated donor is a viable option. So we have a lot of these national cord blood banks around the world. The success rate of getting a donor is very much dependent on race and ethnicity. So about up to 45% of patients do not have a matched donor, either being related or unrelated donor. And of course, the other challenges includes complication related to the transplant procedure itself and the post-transplantation cause of it. And this include graft versus host disease or GVHD, the immune exhaustion in kids who did not receive pre-transplantation conditioning, as well as the behavioral disorder and cognitive defect, especially in post-transplanted ADAs kid patients. So these brought to one of the interesting development in BMT in the field of PID, the haploidentical hematopoietic stem cell transplantations. So in case of unavailability of a conventional matched identical siblings or matched unrelated donor, it is now possible to transplant PID patient with an available haploidentical donor. This haploidentical donor can be a parents, can be their siblings, and or other relative that matches for one haplotype. So this is a very attractive option, as most criterion for an haploidentical transplant is the urgency of the transplant in order to avoid progression of the disease and the unwanted infection. As we know, this is associated with a poorer outcome. And this is making it more attractive because there's a new development in the graft manipulations, and now it becoming a current trend. And these include, firstly, selective removal of alpha beta T lymphocyte. As we know, this is usually associated with reduced graft versus host disease, retaining the gamma delta T lymphocyte, where we know confer positive antiviral effects, removal of the B lymphocyte, and this will avoid the post-transplant lymphoproliferative disease, and other modalities include retaining the NK cells and administration of cyclophosphamide post-transplant. As we know, this will lead to a better outcome in the patient transplanted with haploidentical donor. So why is gene therapy is an attractive treatment in patient with PID? So many will ask, firstly, what is gene therapy? So based on the definition provided by the Gene Therapy Advisory Committee, GTAC, gene therapy is a deliberate introduction of genetic materials into human somatic cells for therapeutic, prophylactic, or diagnostic purposes. So why gene therapy is an attractive treatment in patients with PID? The most important reason for this, as we already discussed, many PID patients lack of HLA matched donor. And in the treatment of gene therapy, as we will see, we do not need other donor, and the patient will be their own source of these stem cells. So this is also will reduce the issue related to the complication, as patients who underwent HSCT with less matched donor are usually complicated with GVHD. And in the case of gene therapy, as the treatment, as the patient is their own donor, this is literally no issue with incompatibility, so GVHD is not a problem. Additionally, as the patient is their own donor, as mentioned, the treatment will have less complication with conditioning regimen and the related problem with immunosuppressive treatment that usually needed post-transplantation in the classical bone marrow treatment. So briefly, how is gene therapy is performed in primary immunodeficiency? So this is a protocol, a snapshot of protocol done in St. Jude Hospital for the case of X-linked SCID. So rather than using another donor, the hematopoietic stem cell will be harvested from the patient, him or herself, and this HSC will then be corrected by introducing the missing or corrected gene into the cells using usually a viral vectors, either a gamma retroviral or a lentiviral. This corrected HSC then will be processed and infused back into the patient, hopefully with transplant at the bone marrow, and generate a healthy blood and immune cells. So again, as we can see in this timeline of gene therapy in PID community can be very proud to see that we are again leading the way in the field of gene therapy. As we can see here, SCID, severe combined immunodeficiency, again leads the way as the first disease to be treated with ex vivo gene therapy back in 2000, and followed closely by CGD and viscoadhesion syndrome. However, for a brief moment, the development was grave with the surprising unexpected side effect of cancer development in patients underwent with the first generation ex vivo gene therapy. And this was mainly due to the unspecific and unwanted insertional mutagenesis in the corrected stem cell that led to the development of this leukemia. But rather than halted the development, this event actually make us learn more and learn better about this treatment and leads to the creation of a better and a safer gene therapy. Thus, this leads to the successful ex vivo gene therapy in 2013 by the means of a better viral vector by using this self-inactivating gamma retroviral as well as the lentivirus as a vector. So subsequently in 2016, 2017, the first ex vivo gene therapy known as Trimvelis for the treatment of ADA-SCID is formally licensed and available commercially. So with the ability, so I think now more than 150 PID patients who did not have a matched donor can be treated by gene therapy since it first introduced into the field of medicine. So with the ability of this treatment, many will ask if gene therapy is better than the bone marrow transplant or the HSCT. So this graph table try to compare both of these treatment in the management of PID disease. As we have more experience in BMT as well as HSCT, it is mostly accessible now, and the survival outcome had definitely improved over time. However, the disadvantage is mainly due to the availability of suitable donor and the related complication related to the usage of alternative donor as the source of this HSCT. So the main advantage of gene therapy, as we have discussed, is mainly due to the not need other HSCT, the stem cell donor. Thus, this is literally no issue with GVHD, as there is no problem with incompatibility. And this is also mean there is less complication with the conditioning regimen, as the regimen will be less intensive. But the main limitation in gene therapy treatment is mainly due to the limited access and the expensive cost, plus as it is relatively a new therapy and our experience is still very limited in the long-term safety as well as the related morbidity is relatively very unknown. So just to summarize where we are now, as shown here, PID, primary immunodeficiency, had definitely leading the way in the treatment of bone marrow transplant as well as hematopoietic stem cell transplantation and gene therapy in the world of medicine. Definitely with more knowledge as well as experience and better technology, we hope that both of these treatment can be expanded to be an effective, curative, safe, accessible, and economically feasible for treatment for many other PID diseases. So as we shown here, we are on the way up, and this is our hope and hopefully the future for the management of PID diseases. So with that, I thank you for your kind attention and for being a very great audience today.